Thank you everyone for joining our monthly webinar. This is a DMC Medical Group Heart-to-Heart webinar series. In these webinars, we try to focus on educational topic related to cardiology and cardiovascular surgery for topics starting from primary prevention all the way to advanced technology in surgical and transcatheter therapies. We are delighted to have Dr. Yusuke Terasaki again. We are coming with a cycle again when the full year is over to talk to us today about infective endocarditis. I'm joined by the co-host with me is Dr. Kenton Zer. He is the medical director of the cardiovascular service line at DMC. With no further ado, I would like to just start our intro video again coming from Detroit Medical Center. So with no further ado, I would like to introduce Dr. Yusuke Terasaki. He is the director of ECMO program at Detroit Medical Center at Detroit DMC Heart Hospital.
Thank you for joining us today. I'm going to be talking about the current surgical treatments of infective endocarditis. I have nothing to disclose. With the Halloween coming up in a few days, I figured I would start this lecture with a bit of a scary story. So maybe those people who are musically inclined might be able to recognize some of these famous people. And maybe even like the lay people may know the one on the very left, even that one I knew. That's Beethoven. The second one is Schubert. And the last one is Dvorak. So you may have heard of these names because they were famous conductors, composers during the classical and romantic time. What you may not have known is that all of them have died after completing their 9th symphony. They were never able to complete the 10th symphony. Now, this last man, Gustav Mahler, he is also another leading romantic composer of his generation. He was born in Bohemia in present-day Austria. Of a Jewish origin. At the end of his career, he was famous for being director of the New York Metropolitan Opera, as well as being the conductor of the New York Philharmonic Orchestra. Now, this man was deeply, deeply superstitious, and he believed in this curse of the ninth, where he would potentially die if he had, finished his 9th symphony. So he had an idea to get around this. And what he ended up doing was that instead of naming his 9th symphony the 9th symphony, he decided to call it the Song of the Earth. And this was written during the time, his darkest time. One of his eldest daughter, Maria, had died from scarlet fever. Because of his Jewish background, he was forced resignation from the Vienna Court Opera. And that's partly the reason why he moved to New York. And he himself was diagnosed with a rheumatic mitral disease. So it was during the darkest time when he composed this so-called the Song of the Earth, trying to get away from this curse of the ninth. Well, you may have guessed, but unfortunately, while after he had finished that and was working on his 10th, he actually succumbed to the complication of bacterial endocarditis on May 18th, 1911, back in Vienna. And he himself became one of the statistics of the curse of the ninth. But what was interesting throughout this story is that his bacterial endocarditis was actually diagnosed by none other than Emanuel Liebman, the famous Liebman-Sachs non-bacterial endocarditis, was also the contemporary of William Osler, by then who was in Oxford, who had moved from Johns Hopkins. Both of them were the preeminent authority on bacterial endocarditis. And he was diagnosed by him through a blood culture that grew enormous change of streptococcus within 16 hours. And this is an actual note that was written from his his colleague to him that Gustav Mahler, they were able to find this attenuated streptococcus in his blood. Unfortunately, this was 17 years before penicillin was discovered by Alexander Fleming, and he just became one of the statistics. It became part of the curse of the ninth. So it's been about 120 years since Osler and Liebman came up with the idea of bacterial endocarditis, and we know a lot more now. So let's start with the epidemiology. So at least from the data, epidemiological data that we have from the developed countries, as you can see from this chart, there's about 1.5 to 11.6 cases per 100,000 in the population. It is still a highly mortal disease process. And even with the maximal therapy, medical or surgical, you still have a 25% mortality. And without any therapy, it's near 100% mortality. Now, interestingly, back in the 1920s, when Mahler was diagnosed with endocarditis, the median age at which people were diagnosed was less than 30. This is the demographics now. You can see that the age has actually gone way up into the 60s, 70s, even 80s. But what was really surprising to me was the fact that there are far, far more male patients with endocarditis as compared to women. And there's a theory that the estrogen in women is protective against any injury to the endocardium of the heart that prevents them from getting endocarditis. But that's only a theory. Now, why else did that shift of demographics occur? Well, back in the 1920s, 1930s, the most common reason why patients developed endocarditis was because patient had rheumatic fever that developed into rheumatic valvular disease, such as the rheumatic mitral disease that you see here in the left. Now, with the advent of antibiotics, rheumatic fever has largely gone in the past. And now, most patients are now getting older and older and developing degenerative, more aortic valvular disease that lead to endocarditis. And that's partly the result of the shift in demographics. The other reason is that there's new introduction to therapies, for example, PICC line, dialysis catheter, prosthetic valves, cardiac devices like AICD that are being placed in more and more older patient population. So if you can see this demographic chart, you can see that, yes, there's an increase in the native endocarditis population, but there's more and more increase in device-related or prosthetic valve-related endocarditis. Now, this chart comes from a study in Spain, and I guess back in Spain, the IV drug abuse-related endocarditis has actually come down over the last 30 years or so. This is unfortunately not true in the US, where we've actually seen a dramatic increase in the number of drug abuse-related endocarditis, as you can see in this chart. How about the microbiology? Interestingly, it's still the same type of microorganisms that are causing the endocarditis from the 1920s and 1930s. You can see that 80% are still composed of streptococci and staphylococci in every region of the globe. And after the strep and staph, you can see that there's an increased number of enterococcus-related bacterial endocarditis. What's also interesting to note is that in about 10% of these patient population, the blood cultures are actually negative. And this is probably related to the fact that the patients receive broad spectrum antibiotics even before blood cultures are drawn. Now, to talk about surgical interventions of endocarditis, we need to talk about the anatomy briefly of the heart. And this is a little blow up of the heart that you can see on the left. The outermost layer is called the pericardium, which is protecting the rest of the heart. And the outermost layer of the heart is called the epicardium, which is where the coronary arteries are sitting. And then you have this little thick layer of muscle called the myocardium. And then within that, the most innermost layer is called the endocardium. And that is basically what comprises the valves that you have inside the heart, which you have 4 of. And inside the heart, you have this aortic valve kind of centrally located, which is very commonly affected by endocarditis, especially from degenerative disease. And then adjacent to that, you have the mitral valve, which was more historically related to rheumatic mitral disease, endocarditis. So for endocarditis to occur, you really need to fulfill two criteria, because a normal valvular endothelium is resistant to bacterial colonization. So the two things are, number one, you have to have some type of injury to the cardiac valve surface for the bacteria to attach. And that could be from a turbulent blood flow from, again, like a rheumatic heart disease or degenerative heart disease. It could be a mechanical injury to the valve, which could be from instrumentation by catheters or AICD or electrodes, or it could be an injection of solid particles that are commonly seen in IV drug abuse. In addition to that, simultaneously to that, you have to have some type of bacteremia with an organism that is capable of attaching to that injured endocardium. And this has to be actually a pretty significant quantity. Now, there have been studies that are done to measure bacteremia, and there's bacteremia actually that occur even with gentle brushing of the teeth. Even flossing of the teeth can cause bacteremia. But that is actually not sufficient to cause endocarditis. So this has to be a big load of bacteremia in addition to the injury to lead to endocarditis. And this is a brief overview of the pathophysiology. You can see that whenever there's an injury to the endothelium of the heart, you basically have platelets and clotting factors that clump together. And this is called non-bacterial thrombotic at the injured site. And then you have this transient bacteremia that comes along, and then it gets embedded inside this clot, and then eventually forms vegetation or growth of bacterial clot inside the heart that could potentially break off and what we call embolize to the rest of the body. And the signs and symptoms are related to where exactly these emboli break off into. So if it breaks off into the optical vessels, these rot spots, we've had patients that had to be enucleated or had the eyeball removed because the eye had become infected. If it embolizes into the brain, it can cause stroke. If it embolizes into the lungs, you can have septic emboli that causes respiratory distress. It can embolize into the abdominal vessels, the mesenteric vessels, and if it goes into the spleen, it can cause splenic infarcts that cause a lot of abdominal pain, same with the liver. And it can go into your distal extremities and cause Janeway lesions, as you can see here in this picture. And obviously, the growth can destroy and destruct the valves inside the heart, as you can see here as well. And you can have this is less commonly used these days, but you can have subacute as opposed to acute, where you have low-grade fevers, malaise. When he was, it's more or less caused by less virulent organisms like strep viridans. In an acute setting, these patients are very sick from overwhelming sepsis, high fevers, hemodynamic instabilities, EKG changes, possibly from aortic root abscesses that cause heart blocks. And they are more affected by virulent organisms like Staph aureus. So as you can see, there are different ways that this disease process can present. And so it's frequently called a great masquerader because it's difficult to diagnose. But the most important method of diagnosis is still probably blood culture. It has where we have to take blood cultures from the patients and determine what kind of organisms reside in it. And this is the most important initial test because this allows us to tailor the antimicrobial therapy. Now, as we had talked about, it could be negative if they had been started on broad spectrum antibiotics prior to the collection of the blood culture. So you had to be kind of mindful of that. And if negative, you might have to get other studies such as serology tests or molecular immunohistological studies. And depending on what kind of organisms that you culture out of the blood, this could affect the decision for surgical intervention. So this is critical for surgeons as well. And the second most important method of diagnosis is probably echo. And a surface echo, a transthoracic echo, is probably the first line type of study that we get on patients who we think have endocarditis. But this could be frequently negative if the endocarditis or the vegetation is small and it's residing on the left side of the heart. And in those cases, it's really important that you not only get a surface echo, but you get a transesophageal, has higher sensitivity to detecting smaller vegetations, especially on the left side of the heart. And this also allows us to determine the size of the vegetation, which is crucial in determining whether we should take these patients to the operating room table or not. A pan scan is also important. These CT scans actually happen to come from prior patients of mine. The one on the left came with a vegetation or endocarditis of the heart. We ended up getting a full body CT scan, and we were able to find this large mass in the ascending colon, which probably resulted in the transient bacteremia that led to the endocarditis. A CT scan on the right basically is a head CT scan that shows septic emboli to the brain. And it's important that we get something like this for patients who we have neurological symptoms, because if they have hemorrhagic stroke, this might be a contraindication to taking these patients to the OR. And with the signs and symptoms that you have with the blood culture data, with the CT scan, then you can go through the modified DO criteria and diagnose the patient with endocarditis. And I'm not going to go through all this table right now. Now, as surgeons, we like to get a further additional workup. And one is probably a CTA, especially if the patient, or if there's any suggestion on the echo that the patient has aortic root abscess, then a CTA will help us look for these aneurysmal dilatations around the root, as you can see here, or you can see abscess forming around the aorta on the right here. And this will kind of give us information to plan out the surgery before we go in. And especially in the patients who already had some type of heart procedure and heart surgery in the past, to get anyway, to see how close the heart is to the back of the sternum so that we don't injure it when we gain access back into the chest. The other study, especially in patients who are older, who are likely to have coronary disease, it's really important that we get a left heart cath as well, just to make sure that we don't have to do a concomitant bypass surgery. However, if the patient has a large vegetation on the aortic valve, this is likely a dangerous thing to do, since the catheter can dislodge the vegetation and cause emboli. So that's absolutely contraindicated, especially if the patient has aortic vegetation. And these patients might be better suited to just get a CTA. So in terms of management, I think this is the most critical point, that it is a multidisciplinary approach to taking care of these patients. It's not just one department that can take care of this patient. Starting from the physicians that admit the patients, the internal medicine doctors, the people who are specializes in infectious diseases. If the patient has any type of neurological process of distal emboli to the brain that requires some type of resection, the neurosurgeons, the neurology has to be involved. If there's any type of abdominal catastrophe that's resulted from the endocarditis, the general surgeons are involved. Obviously, the cardiologists and the cardiac surgeons are involved. And this is, I think, critical that, especially with the drug abuse population, the family support is extremely important, because no matter how well we take care of these patients inside the hospital, no matter how well we do in terms of surgery, if the patients do not have good support outside of the hospital, they're going to just go back to using again and come back with recurrent endocarditis. So family support is critical. Now, the first line management, obviously, is antimicrobial therapy. We typically start with broad spectrum antibiotics until the blood cultures result. And once they do result, we can tailor it to whatever that organism is. And depending on how virulent that organism is, we might need to add on a synergistic antibiotic. IV, but there are studies that I'm going to just go over where you can potentially discharge them on oral antibiotics after transitioning them midway. And you do have to keep obtaining blood cultures every 3 days before and after the antibiotic therapy to make sure that we have a negative blood culture. So this is a study that I was telling you about that comes from the New England Journal of Medicine 2019, where they compared patients with endocarditis that came down with strep, enterococcus, staph aureus in stable condition, who half of the cohorts received only IV antibiotics for 6 weeks, and half the cohort received IV treatment for about 3 weeks halfway, and then they were transitioned to oral and was discharged home. And the all-cause mortality was actually not significantly different. So then, which of these patients end up requiring surgery? So these, I'm adding the class of recommendation based on the American Association of Thoracic Surgery along the side of it to see which patients actually require surgery. So class 1 indications are patients with signs of heart failure. And these are patients who end up in heart failure because they have massive valvular disease, like massive mitral regurgitation, aortic regurgitation, left-sided endocarditis that are caused by very virulent type of organism like Staph aureus, fungal. Patients with persistent sepsis despite adequate IV antibiotic therapy for 5 to 7 days. Patients who develop paravalvular abscess, root abscesses, cardiac fistula, these patients need to go to surgery. Patients who've already had some type of prosthetic valve and they got infected, so those patients typically need to go back in and have the prosthetic valves removed. If the patients keep embolizing because they have a large vegetation load, then these patients also need to go. And as I said, large mobile vegetations that are characterized by being greater than 10 millimeters in size, especially if they're on the surface of the anterior mitral valve, these tend to embolize, and these patients need to go to the OR sooner rather than later. So timing of the surgery, there's not too much data in terms of when we need to take these patients to the OR. There's one randomized study that came out of Korea where they compared 76 patients with similar background, all with endocarditis with vegetations greater than 10 millimeters that were randomized to early, which is described as less than 48 hours after diagnosis, versus conventional, which the median day was 6.5 days after diagnosis when they went to the OR. You can see that there's a significant difference in terms of embolic events if you had waited a conventional number of days as opposed to early, within 2 days of diagnosis. So from this data, there's a AATS class recommendation 2A of taking the patients sooner rather than later if the patient have large vegetations. So as we talked about, some of these patients frequently result in neurological symptoms from emboli. And so how about these patients with stroke? When should we take these patients? Knowing that we are going to have to inject them with very large amount of heparin, 30,000 to 40,000 units of heparin intravenously on top of the patient having just had a stroke. Is this safe or not? Well, this study this is a large prospective cohort study, multi-center from 28 countries, 857 patients with endocarditis complicated by ischemic stroke without hemorrhage, there was no survival difference between early surgery, which was described as 1 week after diagnosis of stroke, and late surgery, which is waiting at least a week after the stroke. There's no difference in terms of the complication afterward. So for ischemic stroke, there's no need to wait. Now, is this different if the patient presents with a hemorrhagic stroke? This is when you have a blood vessel in the brain that had burst, and you were exposing these patients with 30,000, 40,000 units of heparin. Is this a good idea? Well, as you might have guessed, this is not a good idea. There's only one study out from Spain, which basically compared 12 infective carditis patients with hemorrhagic stroke who underwent cardiac surgery thereafter. You can see that the mortality rate was highest when the surgery was performed within 2 weeks after the diagnosis of the stroke. And the mortality went down as you waited longer. And the current AATS recommendation is for the hemorrhagic patients with hemorrhagic stroke to delay surgery for 3 weeks. And that's a class 2A indication. So we have some certain tenets that we follow, especially when we decide to take these patients to the OR. So we need to radically debride all infected material, foreign bodies. If they have a previous prosthetic valve, everything has to be removed, including the sutures, everything. All necrotic tissues has to be removed, all to minimize residual infectious burden. Okay? But radical does not necessarily mean wide margin other surgery or cancer surgery, because if you radically resect part of the heart, we're not going to be able to put it back together. Right? All infected pockets, abscesses that are formed in the aortic root have to be opened up and unroofed, and all pockets have to be cleaned out and irrigated. And as we complete that part of the surgery, the surgeons and the nursing staff have to be aware to change out all the instruments and gloves so that we don't reinfect the sterile part of the patient. So let's go through some of the surgical techniques. As it is most common that endocarditis affect the aortic and mitral valves, here are some examples of what we could do. Now, I've never seen an isolated area of the aortic valve leaflet like this that's cleanly obviously patched with a native pericardium or bovine pericardium. If you have vegetation that is growing over a couple leaflets, then we can resect that and primarily repair it as such. But unfortunately, most of the case, the endocarditis has affected the entire valve, as you can see here, and you do have to resect the whole valve, in which case we'll have to replace the entire valve with a prosthetic valve, as you can see in this diagram. Going down to the mitral valve, again, if you have an area that is affected by the vegetation that we can cleanly cut out like this, we can patch close again with the native pericardium or bovine pericardium like that. And if it's affecting more broadly part of the leaflet, we can do what's called a triangular resection, as you can see here, and put the leaflets back together. Or if it's involving a larger portion of the leaflet, you can do a quadrangular resection. And then most of the time after we do the repair, we put a ring around the mitral valve. Now, what happens if you have a vegetation that grows into an aortic abscess that really involves the aortomitral curtain? Now, that's a very complicated situation where we actually have to take out the aortic valve, the mitral valve, and the fibrous portion that basically bridges the two valves. And you really have to take apart the heart completely. And in that case, you basically open up the left atrium and in communication with the aorta. And you can see that now that we have inserted a prosthetic mitral valve in the mitral position, and then close off the left atrium, repair the aortic root, and then re-implant an aortic valve. And this is called a commando procedure. And it's a very, very technical procedure that most surgeons do not like to perform in this kind of setting. Now that we talked about some of the ways that we can fix these patients, I just want to end this by doing a case presentation of a patient that we saw a year and a half ago or so. And this is a 35-year-old female with a history of very heavy IV drug abuse. She was using about 1 gram of heroin daily into her left arm, who presented with fever, chills, night sweats, and pleuritic chest pain, had this large gaping wound over the left arm where she was injecting with tendons exposing. So very bad disease process. Y count was elevated. She had 3 out of 3 bottles of the blood cultures growing MSSA. She was started on broad spectrum antibiotics, but just like, this is an echo showing vegetation. Oh, not sure if I'm going to be able to play the videos, but this is an echo showing a vegetation on the tricuspid valve and leading to a moderate tricuspid regurgitation. But unfortunately, just like a lot of our drug abuse patients, the patient left AMA and then waited 10 days before returning with altered mental status. And at this point, she was much more sick with the lactemia of 3.0. Her creatinine was up. Her white count was actually down from her first admission, but she had some sort of liver dysfunction with INR being elevated. She had emboli to her brain, which may have caused her altered mental status. She threw multiple septic emboli to the lungs, as you can see here, and was in respiratory distress. She had through emboli to the spleen, as you can see here, with where the emboli was. And you can see how enlarged the liver and spleen is from this disease process. And see if I can play any of these echoes. Unfortunately, I am not able to. But these are echoes showing that now all 4 valves, including the mitral valve, you can see this globular vegetation that's off the leaflet of the mitral valve, as well as the pulmonic valve. You can see that there's a vegetation on the aortic valve causing moderate aortic regurgitation. This is actually showing the pulmonic valve with wide open pulmonary regurgitation, as you can see here in the Doppler picture on the right. So all 4 valves were unfortunately involved. And at this point, after prolonged discussion with her mental status did come back, and we ensured that it did before we proceeded to surgery. She actually had a very involved family. And so we had them involved. And after a thorough discussion with them and describing how risky this procedure was, we ended up taking the patient to the operating room to replace all 4 valves with bioprosthetic valves. Now, I presented this case to show you how complicated not only the surgery is, but taking care of these patients are afterwards. So as you may have imagined from that CT scan of the lungs, the patient went into respiratory failure a few days after the surgery. And we had to put the patient on veno-venous ECMO. And at the same time, we did the tracheostomy on her. Now, with the veno-venous ECMO, we had to heparinize the patient postoperatively, in addition to the fact that the patient already had liver dysfunction with INR abnormalities. The patient bled profusely into the stomach, and we had to have general surgery, open up the abdomen, open up the stomach, and evacuate the clot that was causing the abdominal compartment syndrome. The patient had open abdomen for a few days, and after that, 40 days after the surgery, she then spontaneously bled into the chest, and we had to go back into the right chest through a right thoracotomy and to evacuate the hematoma. It took 56 days, almost 2 months on ECMO before she was finally able to be decannulated. And 117 days, almost 3-4 months after surgery for her to be discharged to a subacute rehab. She was unfortunately readmitted back with respiratory failure and was in the MICU service for an additional month before being discharged again to subacute rehab This is already 214 days, almost 2/3 of the year gone after surgery. Fortunately for her, as I said, she had a very supportive family. And a year and a half later, she came back to my surgical clinic, walking in, even though she had some oxygen tank, 2 liters of oxygen at home. She walked in, everything recovered from her left forearm to the sternotomy site, to the tracheostomy site. And she looked like a brand new person. But, and then this is the CT scan that showed this large bleeding into the stomach, for which reason we had to take the patient to the OR for an X-lab. But as you can see, taking care of endocarditic patients is an extremely involved process and very multidisciplinary. So the take-home messages that I have in regard to taking care of these patients is that this is a disease. It hasn't changed in the 120, 30 years since Gustav Mahler died. Still associated with very high mortality, even with surgery, even with the maximal medical therapy, still very high mortality. And it's critical to have a multidisciplinary approach, as you can see from the case presentation. And the timing of diagnosis and repair is important, as we talked about. And it is an extremely technical, it could become a very technical surgery that requires the maximum amount of preoperative planning. I'm going to end my presentation there.
Thank you so much, Dr. Saki. We have a few questions coming in. I just want to give the platform to Dr. Kenton there to have any comments.
No, I mean, I really appreciate Yusuke's thorough review. And also, that case is an exceptionally good case to highlight all the problems with multi-organ system failure that we see with endocarditis. You know, as Sir William Osler said, it's the great masquerader. One of my most recent endocarditic patients presented back this summer with a subarachnoid hemorrhage. They had no idea why, but it turned out to be a septic emboli, and she was not diagnosed for 4 months until she threw another embolism to her shoulder and presented with shoulder pain. And so embolic phenomenon can occur anywhere. They can go to the eyes, like Yusuke said, they got eyes, the brain, and everything. So we have to have a high index of suspicion, particularly where there's high risk behavior. Chadi, I think we should start going through some of the questions. I noticed in the chat room, there's a few interesting questions.
Absolutely, yeah. So first question coming, do you approach myocardic aneurysm patients similarly to other hemorrhagic stroke patients with endocarditis? I think the question, would the presence of myocardic aneurysm will alter that decision for surgery versus not?
That doesn't happen very often. Sometimes, you know, we've gone after them with a minimally invasive way with neurology to try to address them before. It's pretty unusual. I mean, if they're not, I think, you know, Yusuke summarized that pretty well. If it's not hemorrhagic, we don't worry about operating on the patient, even in the setting of a potential myocardic aneurysm. But if it is hemorrhagic, we try to wait as long as we can. But there's a recent paper out of the Cleveland Clinic by Gustav Pedersen that showed if you have solid indications for surgery, you shouldn't wait despite what's going on in the brain, because you'll lose them because of the other complications, such as, you know, florid heart failure, the inability to have source control where you continue to throw emboli despite the fact that you're on antibiotics, patients that do not respond to antibiotics and continue to have, positive blood cultures despite maximal antibiotic therapy. Those patients we tend to proceed on almost regardless of what else is going
on. How many blood culture do you have to be negative prior to going with surgery?
You want to take that, Yusuke? I mean, I would answer that by saying one of our most common reasons for going to surgery is not having negative blood cultures.
Yeah, because it's still seeding into the blood.
Right.
Yeah.
The persistence of positive blood cultures despite maximal antibiotic therapy is a good reason to proceed. That's a class 1 indication to proceed with surgery. You know, what we call source control, failure to control the infection.
Mhm. How long after the procedure do you have to obtain an echo to evaluate that the valve or the procedure is, you are completely free of vegetation?
Well,
I would say after the surgery, you do not need an echo unless you have some suspicion that the patient developed recurrent endocarditis, or if you're trying to rule out some type of valvular failure. So without that, I don't think there's a necessary indication to follow up these patients with echo inpatient. The patient can probably follow up with the cardiologist or cardiac surgeons 3-6 months after the surgery, just for follow-up echo, but not necessary as an inpatient.
Dr. Mukano asking a question. We tend to have a more lenient, relaxed approach to tricuspid endocarditis compared to other valves. What's the reason?
That is true. And I think it's related to the fact that it's on the right side of the heart. And if it causes tricuspid regurgitation, the patient don't necessarily develop the heart failure to the extent that the left-sided valves would cause. But having said that, I think if you leave these patients with severe tricuspid regurgitation for too long, the patient does develop chronic RV failure. And so these patients will have to be operated on eventually. But it's not as urgent as left-sided valves for that reason.
There's one caveat to that, though, Chadi, and that would be a patient with a PFO. And we've all taken care of patients with tricuspid valve endocarditis where we open them up and we see a clot halfway through the PFO caught in the middle. And of course, we always take a photo of it, but that's happened in my career several times where there's one caught in between. It's in transit. It's a septic emboli in transit between the right and the left side of the heart. So it's a very important to notice on the TEE whether or not there's a patent foramen ovale in patients with right-sided endocarditis, particularly. I want to point out that experiment has already been done in the past. There's a historical paper from Henry Ford many years ago where they took a series of tricuspid valve regurgitation patients and just cut the valve out and didn't replace them and just left them with florid, with no tricuspid valve for an extended period of time. Most of those patients did quite well for a long period of time, but because the right side is volume overloaded, over time, they end up with right heart failure. So Yusuke's point about right-sided failure being an indolent chronic problem is real, and we can't ignore right-sided disease, that's for sure. But we usually do give them more time, even with bigger vegetations, to see if we can sterilize their blood and maybe tune them up and wait a while, get their heart failure better, and get their source control, get their control of their infection, under better control, say.
One more question related to non-bacterial thrombotic endocarditis resulting in severe valvular damage, regurgitation. How do you approach that? What would be your surgical approach, or would you do surgery in this patient, which is non-bacterial thrombotic endocarditis?
Whether the patient has infective or infectious or non-infectious endocarditis, if there's severe valvular disease, as in mitral regurgitation or aortic regurgitation, the patients are going to develop heart failure no matter what. And these patients they don't need maybe emergent surgery as you might in infectious endocarditis, but these patients will definitely need urgent surgical valvular repair or replacement.
How long would you wait for a, just want to summarize, like if we do an echo, what would be our parameter would say, this patient, regardless how long you give him or her antibiotics, the patient need to go for surgery. Is there any morphology on echo that dictate indication for surgery?
Yes.
Well,
yeah. Go ahead.
You mentioned one,
classically,
I just want to summarize to the audience.
Classically, we used to say that if the vegetation was greater than 1 centimeter, then there's more impetus to proceed. Now, that's been kind of debunked more recently, but still there's this scary factor that you have as a cardiologist reading the echo, and we have when we're looking at the echoes, that you say, oh my, if that was on my valve, I would want it out, because I certainly don't want that going to my brain. So I think that the mobile emboli, and as Yusuke knows like I do, when you go in the operating room and grab those vegetations with a pair of pickups, they flake off just like whoosh, they're off the valve, and you're like, how in the world did it go back and forth so many times on every beat without embolizing? So they're really friable and fragile, and that's why they do take off at times. So I think there's that scary factor. But then the other factor is, what is the organism? Because particularly in the mitral valve, a lot of the patients that present with endocarditis are very young. And the options for a mitral valve with tissue, the longevity of a tissue valve in the mitral position is not very good. So we try to fix those valves whenever we can, even in the presence of endocarditis. Cut out the vegetations, patch them, with bovine pericardium or autologous pericardium, and try to fix them. And we wrote a paper from the Mayo Clinic in the 2000s, between 2000 and 2005 or so. And it was looking at acute endocarditis of mitral valves. And we found out that if it was Staph aureus and you didn't operate on them early, the chance of fixing them was low. So it was definitely better to take Staph aureus earlier to the operating room. The streps, you could wait longer because they didn't destroy the valve as quickly. The organism was not so virulent. The other thing we found out, that if you had to replace the valve because it was destroyed, a fair number of those patients came back with recurrent endocarditis, whereas in the same series, all the patients that were repaired, nobody came back with recurrent endocarditis, not a single one. Pretty small series, but accentuates a few points. Repair, if you can, is better than replacement, particularly in the mitral position where the durability of a tissue valve is probably not past 10 years. And secondly, if the organism is virulent like staph, you should likely intervene earlier, because staph is very difficult to eradicate without complete destruction of the valve.
I want to put a plug for this paper. I wrote it with other colleagues. Humam, as you know, Dr. Zara is coming to be our interventional fellow in a few months. But I wrote the paper, I think, in 2018. So maybe it's a little bit outdated. I just want to see if it's true. So we asked this question in Cleveland Clinic Journal: how soon should patient with infective endocarditis be referred for valve surgery? I have a short summary called 1-minute consult. And we came with this algorithm based on the AATS guideline. But I think part of it is, as you said, debunked. But again, just want to walk to see if this is an accurate summary for primary care, general cardiologists who are taking care of these patients. Number one, if you have severe valvular dysfunction, obviously, if you have destroyed valve, as you mentioned, due to virulent, or the patient have edema or heart failure or symptoms of failure, meaning they start to have mechanical complication, or uncontrolled infection, meaning no clearance, to the question of the audience, if the patient does not have any clearance of a blood culture or have abscess or AV block because of the aortic valve involvement and the involvement of the His-Purkinje fibers causing a complete heart block, or you have a high embolic event. Again, I don't want to confuse the audience with a 10 millimeter cutoff, but again, if it is big, if it is risk for cerebral emboli, or a patient has cerebral emboli, maybe the patient should be expedited for surgery and don't wait for the IV antibiotic to work, or at least it's not going to work in this situation. What do you think? Is this summary still applicable or need to be modified?
Well, I mean, I think that summary is pretty much what Yusuke's slide was as well. Yeah. Looking at class 1 indications, pretty much every one.
Yeah, sure. With the difference that I think, early in the paper that I showed meant less than 48 hours after diagnosis, as opposed to 7 days. So I'd
to
say early
within 2
surgery
days.
would be like within 2 days of diagnosis. And that is why I think it's critical that whoever is taking care of the patient first, they really need to involve the surgeons sooner rather than later, not after all this workup has been done before they call a cardiac surgery consult. But as soon as they are concerned that the patient has endocarditis, just involve us.
Yeah, absolutely. I think we're coming 8 minutes left. A question related to post CABG or post valve or choice of valve. Quick comments about who get mechanical and who get bioprosthetic.
This question always comes up.
This is unfortunately unrelated to endocarditis. The decision of mechanical versus bioprosthetic should not be altered by the fact that the patient has endocarditis.
Absolutely.
If the patient has an indication for mechanical, he should get a mechanical. If the patient has an indication for bioprosthetic, he should get a bioprosthetic, regardless of whether the patient has an infected valve or not. Because it's been shown that it does not matter whether you get a mechanical or bioprosthetic, the patient's recurrence rate of prosthetic endocarditis.
Now there's a few subtleties about that. I think it's fair to say, looking across the literature, the de novo infection rates of valves, in other words, putting a valve in a human being without endocarditis, has a per year infection rate associated with it. It's exactly the same for mechanical valves as it is for tissue valves. Depending on what you read, 0.1 to 0.3% per year get infected. So I think you can say that if you put a valve in an endocarditic patient, you're going to end up with the same rates with each one, using that data of first-time valve replacements in human beings. So I don't think it really matters. Now it is true that there's one category of valves that are very resistant to infection, and that's homographs. Human cadaveric valves, which are thawed at the table and used to replace portions of the valve and portions of the aorta, and even in the commando operation, the whole mitral valve, the whole aortic valve, and some of the tissue. Now that has been written about extensively. And if you have annular involvement, annular abscesses, horseshoe abscesses of the aortic root, there is no doubt that a homograph reconstruction is a better reconstruction for that patient than prosthetic material. Like,
what is horseshoe, Dr. Zair?
Well, a horseshoe abscess, the abscesses at the aortic root tend to be horseshoe type. They tend to be, they tend to erode from where the septum is, that tends to be spared. But all the other circumference of the root is abscessed. And we see that in advanced aortic root abscesses, particularly in prosthetic valve abscesses. And those patients, there's no question that a homograph reconstruction is more resistant to recurrent infection. I mean, John Kirkland wrote about that back when he was in University of Alabama. Haydock was the first author on that paper. And they showed that 40 years ago that homographs were a durable reconstruction for aortic root abscesses. So,
question about any experience in TAVR-related endocarditis.
Sorry, what?
TAVR-related or TAVR with endocarditis.
I personally do not have an experience with TAVR-related endocarditis. But
I mean, I've done two that I recall. I treated them just like, I think Yusuke did one of them with me when we were at Hopkins together. So we treat them just like any other,
prosthetic infection.
Yeah, any other prosthetic valve infection. The only difference is if there's I did a endococcal infection of a patient that had a core valve. So, the core valve struts come very high up in the roots. And she had two of them. She had a valve and a valve, and she was 84. And that was very difficult to get out. We had to use ice and tease out each prong to peel them away from the aorta. But otherwise, we just treated it like a regular valve.
So question came to my mind is, so would you approach bioprosthetic infected valve different than native infected valve? Would you have a lower threshold for being aggressive and because this is a bioprosthetic valve?
Yeah, one of the indication for being more aggressive is prosthetic valve endocarditis, as I showed in the list for having a class 1 indication for surgery.
So, but maybe TAVR can fall into this. Then we have to have lower threshold for getting on. Yeah, good. All right. I think we're coming to top of the hour. Two more minutes left. I just want to highlight to the audience that these lectures are recorded and they are hosted on the DMC Medical Group YouTube channel. This video will be ready within 7 days to be watched again. With all these questions and discussions will be all included as well. So it can be used as a reference in the future. Again, we'd like to highlight a few things related to a DMC center for any aortic dissection or cardiac emergencies. This is the number that can be called. This can be called for any consultation, patient who are required urgent emergency care or urgent cardiac care. I would like just to highlight this number for the audience. With that, I would like to thank Dr. Terasaki for his time. It's been a very informative evening lecture, information and up to date and very entertaining at the beginning. You got us really hooked up to the talk with this interesting fact at the beginning. And thanks for all the audience who joined, to Elise Bennett for putting this program together and for supporting this webinar. And thank you all for joining us too late this evening. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.